directory. With that, my dear friends, let me invite everybody to move forward. And with that, we are flipping the page to another subject for discussion. And please welcome our next speaker to discuss the problem of hospital-acquired infections in surgical hospital settings during the war. So please welcome our next speaker, anesthesiologist, deputy chief physician of Feofania Clinical Hospital, PhD in medicine, associate professor at the Department for Anesthesiology of the National Medical Academy of Postgraduate Education, named after Shubchik, Dr. Andrii Strokan. Thank you so much, and warmest greetings, my dear colleagues. This would be my honor to be addressing you from this stage, and particularly here in the presence of our international friends. And the title, which you can see in the slide, is one of the top priorities, and I'm sincerely convinced in the relevance of this subject, because the current situation, including clinical situation we observe in Ukraine, is different from the rest of the world, given the scale, the gravity, and complexity of this armed conflict, which is actually the war we are part of. Speaking of disclaimer, I don't have any conflict of interest, but please look at this fresco dated back to the 12th century, because it's quite demonstrative of the situations that we observe currently in Ukraine. And with that, going to the picture when the bullet is extracted from the beating heart of one of the Ukrainian servicemen. I believe you are familiar with this picture, which was taken on the third week of the war. But looking at this chart, let us try and see what is the relationship between bacteria and the war in terms of dynamics. This spike is the time when Ukrainian troops were withdrawn from the Baltsevo. At that time, we didn't have such big-scale warfare, but our hospital admitted 170 patients over the matter of 5 days. And looking at the prevalence of Pseudomonas aeruginosa and Acinetobacter baumannii, which back in those days we thought would be our major headache and the challenge, but the situation changed dramatically soon after. And again, these were all servicemen admitted to our hospital. And speaking of the relevance of such problem, here's a publication by the World Health Organization emphasizing that, particularly when it comes to inpatient care, we have almost 25% infected in nosocomial infections in the inpatient settings. Many of them might be admitted to intensive care units, and the prevalence of mortalities induced by such sepsis in ICU settings is quite high, despite all the modern care solutions available. Florence Nightingale, the first description of infections in wounded and why this results in their lethality, despite intensive care efforts. And this has been described ages ago. We remember the publications by Pirogov, then by Nightingale, and now we can see the face of our major enemy. And looking into this list, this is can be transliterated into escape, which is the most common group of pathogens globally, but in Ukrainian case scenario that would be CAP, K-A-P, with Klebsiella, Acinetobacter, and Pseudomonas, respectively. If you perform a culture testing of your patient, you will see these top 3 favorites at the top of the list. In Ukraine, everything was quite challenging even before the war started. Here you can see the data as of 2019, and resistance to carbapenems was 61%, and Klebsiella 61, Acinetobacter, respectively high enough. But now, converting that into a pie chart and other graphs, wait a second, these buttons are malfunctioning or disobeying my clicks. So again, here, unfortunately, we are sharing the same geographical space with our northeastern neighbor, and the situation with Klebsiella is comparatively better, but speaking of the rest of the pathogens, this is still alarming. Thank you, dear Dr. Homanuk. With your assistance, we have managed to break this ice in order to enable civilian hospitals to accept servicemen. And here you can see some of the statistics of 23 examined patients which have presented at a time to our anesthesiology and ICU department. But interestingly enough, in 3 patients only, there was 0 cultures, while most of them had 3, 4, and even a greater number of cultures. And looking at the results of our cultural studies, this would be the group of enterobacteria, which should be dominated by E. coli, but in our case, that was Klebsiella pneumonia. And I'm sure this would be a similar case scenario in any ICU department in the civilian sector, which is dealing with the servicemen. But also look at the blood. Gram-negative flora is also getting their numbers high. And again, this is cumulative for 2022 and 2023, but situation is developing in a dynamic manner. Central catheter complications. That's another phenomenon we are discussing with the military medical units in order to make sure that the stable patients should not have the central venous catheter installed. But majority of the patients coming following such catheterization, they come already infected with Klebsiella pneumonia, Acinetobacter, and the P element as well. And that is something to remember of what and how should be done at the stabilization point. Yes, you are saving the life, but the central catheters resulting in the catheter site infections and prevalence of resistant strains. Looking at this chart, we also can see that namely gram-negatives are dominating in the statistics, and that would be similar in any other inpatient care facility. So the situation we're observing at the moment is resistant to 3 strains of Klebsiella, different subtypes of Klebsiella, all of them being susceptible to different extent, but in most cases this is multi-drug resistant. So we have to use customized solutions in terms of antimicrobials to select. And this is due to the multi-stage evacuation and referral system when the patient can travel to different hospitals. So I do remember a patient case when such wounded serviceman has traveled between 4 different hospitals within 2 days, within 48 hours, being administered with different antibiotics on that pathway. And again, now in the context of war, the efficacy of coordination in such referrals can be compromised. And again, the KAP is in the dominating priority list. But why is it so? We understand that everybody tries to make everything possible and beyond that in order to save the life of our wounded servicemen. But that results in the problem primarily being triggered by administrative and financial reasons, as well as lack of communication and coordination, which results in high infection rates with nosocomial infections on the one hand, and the problem with the antimicrobials as well. In some cases, you have to use whatever you have available. And due planning, procurement, and supply of antibiotics can also be challenged or even disrupted because of logistical issues. And that, to some extent, is also serving as an explanation to our current status quo. So this combination of administrative, financial, clinical, factors are resulting in such disadvantaged situation when we have major difficulties, thus triggering additional problems to the future management of such patients. And again, sometimes you don't need a miracle to happen in order to improve the situation, because sometimes the appropriate referral of the patient and appropriate management of the patient in different stages can become a helpful solution. Let us take a look at the medical evacuation pathway from the American sources, which is impossible to implement it in Ukraine because we have to deal with a mean aggressor who is targeting civilians, who is targeting medics, and that is where and why our medical evacuation in Ukraine is impossible. Full stop. Only when it's the safer neighborhood, Dnipro, Zaporizhia, question mark again. Even in Dnipro, this could be challenging. And thus, we understand there are collecting centers where the injured servicemen are collected for future referral, and then only they are dispatched to safer neighborhood. Thank you, dear Konstantin, for sharing this chart. And here we can see obviously now that it's the second and secondary and tertiary level when you have the greater number of patients which require additional referrals. But at the same time, remembering that timeliness is also a factor. There are cases when our patients, which cannot be transported because of the lack of vehicles, medical evacuation vehicles, helicopters, these are primary targets for the aggressor, and that is also a factor to take into consideration. For example, I do remember recently we had a patient who spent 4 full days in the battlefield because there was not a single evacuation vehicle available in the neighborhood. And this is just one of the extreme examples. But even if it were 3 days instead of 4, that would also make this case extreme. So with that, let us look at the major problems we have to deal with. First of all, these would be the wounds, contaminated and infected, depression, additionally to that, and other mental health and emotional disorders, pain to manage. And in this slide, you can see one of the typical pictures in our settings. And again, tourniquets, particularly inappropriate use of them, and long evacuation time, which results in the prevalence as high as 70% of our patients with such complicated and multiple traumas requiring hemodialysis. But sepsis on top of that, cardiovascular arrest. And looking at the SOF ratings, the survival rate for such patients is very low, but we are managing to save their lives.
It's extremely large, the problem with our treatment of the patient, and my personal thought that concerning the infection control from the point of view of audience and the point of view of authority, what should happen with these patients? The first one, the healthcare ministry and the local administration of the hospital, and third, the adequate antibiotic therapy in order to prevent normal situation with antibiotics, because we are only the country in the whole world that has face such a huge problem, and it's impossible to see that any company will produce a new antibiotic for us. According to the healthcare ministry, they worked very well, and because they published to great report and to great order, but the main problem still exists is the financial, because it's impossible to implement it without any appropriate financing. And from the point of view of local hospital, we can provide a lot of orders and a lot of authority, but from the technical point of view, it's really challenging. And look at World Health Organization. We should isolate the patient with nosocomial infection. But if we see the real situation, we can observe that half our patients are infected. But Soviet system of buildings, we have at least 2 patients in one ward. But it's sometimes it's given 4 and even more. But so from this point of view, it's almost impossible to isolate infected patient. Another problem, the lack of personality. Another kind of problem is personal hygiene, hand hygiene, and sometimes we forget about that because it's obvious that medical personnel is one of the main factor who provide this nosocomial infection, and especially the local surgeons. And we have to understand that surgical nurse, this is the one who wash their hand properly, but not the surgeon themselves. So what is the main measures? So carbamazepine-resistant bacteria, Acinetobacter pneumocomatosis, isolation of the patient. And moreover, we've got a lot of isolating gowns for after COVID, but according to our personal experience, we can say that we put all the human aid because there is no one who want to take it, but we have to understand that any personnel who contact with the patient in ICU should have a special gown and should be isolated from the. Another one problem. This is a transferring of the patient. So this is the main problem that everyone have to want to say that it's my patient and you should transfer it. And a lot of patients who are delivered over our clinics. Single usage instrumentary is another problem. And I have to say that we have an experience in Mayo Clinic, and we can say that every patient over there has a special single-use cuff for tonometry. And every patient has her own, but under our reality, it is impossible to see the situation. So the same cuff for all the patient, and we can understand that this require a lot of payment and financial. So another question is prioritization. So isolation, preventing measures. And we have to save antibiotics because we have situation absolutely because clemenzine is a baseline treatment for our patient. So and what we have in the further, so there are a lot of microorganisms, they are naturally have their resistance for these antibiotics, and that is why when our stationary because and we reveal a lot of microflora that are totally resistant. So the first group who is less productive or carbamazepine, and what should we do? And we have to switch on piperacillin and tazobactam. And if you have a MRSI, and we can use meropenem, and if we beta-lactamase Psi, and we have to save carbapenem and base your therapy on ertapenem, and after then to switch on ertapenem. And if you have the microflora that totally resist carbapenem, so and you have to switch on scheme of usage Zalitsev and Dastoyanam in order to for the usage taxicillin as a reserve antibiotics, because we will further have the situation no antibiotics therapy at all that we could use to treat the patient. So what good have we observed during this week? First of all, one the problem. Our main problem is catastrophic running out of our personnel because they are totally worn out, they're totally exhausted. This is a really catastrophe for them. They are totally exhausted. The next problem is a lack of medical personnel, and this is impossible to absorb prioritization because it is impossible to earn real money in medicine right now. And really challenging to motivate personnel without additional earning and additional payment, and we have a lot of patriotism under these circumstances, especially medical nurses and even there. And the next question is psychological burden of this patient because
So we should also be mindful of the emotional and psychological tension because these additional burnout effects and syndromes are aggravated. And then the lack of space and appropriate space management in the clinics and impossibility to isolate the patients with nosocomial infections because they have to be placed into isolated rooms. They need specially designated medical staff. And what is the solution here? Surprisingly enough, there was an idea suggested by my colleague from New York who's managing a private clinic, who said that in their outpatient care unit, which is performing prosthetic care services, again, private clinic, outpatient care, prosthetic services. They have only 0.05 as the level of nosocomial infections. And they are managing to sustain such low prevalence of antimicrobial burden because 3 is the maximum allowable. Looking at those numbers, my eyes are opening wide, but at the moment we don't have any solutions available because our inpatient care facilities within the entire healthcare system, they have no right to perform any outpatient surgical interventions because of the regulatory limitations. But again, speaking of that clinic where they have 330 patient bed capacity with 75 of them for ICU, which means you need at least 25% of your patient bed capacity share reserved for intensive care and anesthesiology. And now let us look at our job descriptions and the flowcharts of our clinical performance. But again, there are some successes. One of them is reduction of the so-called frontline duration by 1, sometimes even 2 days. And also the number of intermediary hospitals involved in medical evacuation is also going down. The fact that some of the civilian hospitals have changed their profile of their functioning and providing assistance to the military medical sector is also an advantage, particularly in the areas where they don't have any baseline knowledge. They are acquiring such knowledge and skills intensively via additional training of their staff and acquiring the best available modern techniques. But if we could benefit from assistance from our American and European partners to strengthen the capacity of the entire system, that would be quite important. Because without such assistance provided regularly throughout these periods, we would not have survived. And even now, we rely from 30 to 40% on the humanitarian support coming in terms of medicines, consumables, and medical equipment as well. So we truly and sincerely appreciate all of the support that you are generously sharing with us. With that, driving towards conclusions, findings, and recommendations. First and foremost, the system has to be transformed. We understand that any reform and transformation in the wartime is an extra burden and challenge, but that is something to be done. Further on, despite the war, and this is my personal and professional opinion, we have to build new hospitals with new design of the facilities, society with a new school of health professionals being involved as this for staffing, because half reforms and half transformation, some cosmetic changes, they won't be effective. So sometimes we have to build such clinical centers starting with a scratch. And here's a reference to one of the articles to an American publication where authors are also sharing their view and findings and as well as solutions to improve the current situation with the clinical care, but also importantly enough, the flow of humanitarian assistance and supplies should also be transformed. Because this is not the matter of sharing with us whatever is the leftover in your stocks sitting at the warehouse or something with expiry days due. This assistance should be targeted to specific needs of particular facilities, particular services, particular regions, because in most cases, looking at the inventory list of the humanitarian supplies, we see the same old style supplies which we've been shipped for years, but sometimes we have gaps in what we actually need. So here, appropriate communication, planning, and coordination would also be helpful. Thank you so much, dear Andrii. This was really eye-opening in some respect, and I can see the hand raised for a question. Yes, let us enjoy this moment in time. We have just 2 minutes. 20 seconds, if I may. Thank you. And thank you, first of all, for your job, for your presentation, and for our productive collaboration. We do appreciate that. My question is about the synergy of antibiotics. Do you conduct any research on that using antibiotical combinations? Is there any progress, or is it in decay? As a matter of fact, we do. Our microbiological laboratory is trying to work hard, as well as the reference laboratory in Kyiv. So the synergy in antimicrobials use is under study, but that is supported by our cultural investigations. And unfortunately, when we have the as some strains which are resistant to everything, then synergism is the only solution. I do understand there is lack of evidence. We also appreciate this challenge is not so burdensome elsewhere in the world, particularly in Europe, and we have to be inventive and creative enough. Sometimes we manage to help our patients. These are exceptional cases. A lot depends also on the wound care performed by the surgeons, additionally to the antimicrobial intervention. But again, these are exceptional cases. And we have indeed to generate the new evidence. With that in mind, let me invite you to join our efforts in this respect, because again, we're also trying to be creative, but this is a challenge for everyone. Excellent. This is a wonderful start of potentially promising collaboration that we have become witnesses of. And if there are no questions, then please be invited to continue communication over the coffee break. And with that, we're moving to another